Hi, I'm Jack Cush, and this is an RAQD clinic. These are brought to you by BMS. Today's case, hard decisions in an old person who needs therapy. An 80-year-old woman who has rheumatoid arthritis for 34 years comes to you. She's doing poorly. Last year, she was diagnosed with CLL and ITP and small cell lung cancer, and she's been treated with chemotherapy and said to be in remission, although she's currently under care by the oncologist and by you, the rheumatologist. In fact, she's missed a few visits with the rheumatologist and now sees you because it was assumed that they would take care of her RA with all of her cancer care. Her current medicines is methotrexate 25 milligrams a week as a sub-Q injection. She's on a non-steroidal, takes some PRN Tylenol, and that's it. In the past, she's been treated with etanercept, leflunomide, hydroxychloroquine, sulfasalazine, gold, and TNF inhibitors. She was taking adalimumab at the time that she was diagnosed with ITP, CLL, and the cancer, and hence they bailed out on further biologic therapy. She's only received the TNF inhibitor. So currently, she's got pain at 7 out of 10. She hurts kind of all over, small and large joints, 60 minutes of morning stiffness, 12 tender joints, 5 swollen joints. Her CDAI score is 25, very high. She has Medicare. And the question is, what are you going to use to treat her RA? Here are your choices. 1, let's go with A. A, your choice is let the oncologist treat her RA. B, you treat her RA and change her therapy by adding a DMARD. C, let's go with abatacept. D, I like Actemra or tocilizumab. And E, and another person's thinking rituximab. The question is, what would you choose and why? So this is not an easy case. It's kind of complex. It's age, it's multiple drug failures, it's concomitant medical conditions, and a cancer care thing. First issue, number 1, elderly. The elderly are big time untreated by you, me, and everyone else that treats RA. I don't know why. I think it's because they're older and there's some financial restrictions, but really I think people are afraid to give advanced therapies, aggressive therapies, to people who are older. Guess what? Our best drugs work in the elderly as well as they work in young people. And the thing is that we don't use them because we're afraid to use these more aggressive therapies. Second, cancer. I said it before, I'm going to say it again. Let someone else take care of the cancer. You take responsibility for what you do well. You know the other person, the oncologist or the obstetrician or the family doctor, or I don't really care, they can't manage RA. They don't want to manage RA. Their life is too busy and complex, and they want you to manage it. You manage the RA to the best of your ability. Let cancer be taken care of by the oncologist. 3, the elderly have a problem with polypharmacy. Well, she's not really taking much. She's getting chemotherapy Q3 weeks, and she's on very little for her RA, so that's not really a problem. But yeah, the elderly, polypharmacy is a big problem, which adds to their morbidity, if not drug toxicity risk, etc. But so it's something you keep in mind with the elderly. Money's a big issue, the 4th issue here, and her main source of payment here is Medicare. So if she were destitute with no insurance and no income, I could get her any drug here in the United States for free through compassionate use. But if she has Medicare, you really can't do that. It's hard to do that. But someone who has no insurance and again is in the poverty level, you can get any drug you want. You just have to apply and find out from the company what the process is, and you can get whatever you want. But the fact is, this patient has Medicare. So there are certain infusible medicines that may be preferred in this patient. And that does include abatacept, tocilizumab, and rituximab. These are the same choices that we had in our last case. They all apply here, and they're all well tolerated, and we can all be used concomitantly with her chemotherapy. So you just send a note to the oncologist, this is what I'm going to do. If they know what they're doing, they'll have no problem with it. If they come back and tell you, oh my God, you can't use IV abatacept while I'm using a checkpoint inhibitor. Well, that actually is true, right? But other than that, you could pretty much use any therapy while they're using either checkpoint inhibitors or, cisplatin related drugs or there's a billion and one different drugs that people might use, most of them cytotoxic. They can go very well with your biologics. Again, be aggressive in people who need aggressive therapy. RAQD clinics are brought to you by the sponsor of this month's campaign. That would be BMS. The campaign's called Hard Decisions in RA. Tune in for more QD clinics.